Chapter 1: Patient Assessment. Each patient that seeks an implant treatment is different and may present different challenges to the clinician. A meticulous patient assessment is of utmost importance to ensure the success of an implant treatment. Following this chapter, students will be able to discuss factors that influence the outcome of treatment and identify aesthetic risk assessment used for planning implant cases. There are many factors to consider that may influence the outcome of treatment, and they can be grouped into patient's expectation, medical condition, and local dental factors. As with any dental treatment, it is important to ascertain patient's expectation of the final treatment outcome. Patient's expectation of the implant treatment may be gauged from the purpose of seeking treatment, whether for function or to improve aesthetics. Cosmetic reasons would normally be associated with higher aesthetic demand. In such cases, it is important to assess whether the demand is realistic, feasible with the present clinical condition, proposed treatment, and the skills of the dentist. During the assessment, it is also important to rule out any medical condition that may pose significant risks for any elective surgery, as this would also apply to implant surgery. The following are examples of groups of patients who may be at risk for complications during or after implant surgery. Immunocompromised patients or patients on immunosuppressive therapy include those with congenital defects of white blood cells or complement factors, or organ transplant patients. These conditions make the patient more susceptible to infection and also result in poor wound healing. It is best to delay any elective surgery for patients who had recently suffered from a cerebrovascular or cardiovascular event, as these patients are at risk of developing another episode of attack or suffer complications during surgery. It is best to consult with a medical counterpart when planning an implant surgery for these patients. Patients with cancer usually receive a combination treatment which may include chemotherapy and radiotherapy. Depending on the dose or cycle for chemotherapy and location for radiotherapy, these patients are at risk of developing complications during or after surgery. Patients who have undergone radiotherapy are at risk of osteoradionecrosis and pose with significant risks of implant failure with higher doses of radiation. Bisphosphonates are used to treat conditions with abnormal bone osteoclastic activities. Depending on the route of administration and dosage, this may pose a great risk of bisphosphonate-related osteonecrosis of the jaw, also known as bronch. Patients with life-threatening allergies to medication and metal are not suitable for implants. Isolated incidents of allergic reaction to titanium alloy has been reported to contribute to implant failures in patients who are susceptible. Local dental factors to be considered during implant planning are prognosis of the tooth, number and location of missing teeth, bone availability, anatomical landmarks, forces to the implant, restorative space, and soft tissue factors. Some examples will be given in the following slides. The decision to maintain or extract a tooth must take into consideration the diagnosis of disease, condition affecting the tooth, and also the prognosis. Diagnosis or nature of the disease or condition is made following collation of data from history, examination, and special investigations. Prognosis is the prediction regarding how a tooth and its supporting structures would fare in the mouth and the likely course and outcome of the disease or the condition that is affecting it. The decision to retain a tooth followed by restorative treatment, as opposed to extraction and implant, must take into consideration cost-benefit analysis for the patient, including number of visits required, cost of treatment, and maintenance. Some common diagnoses have been summarized in the table. Missing tooth or missing teeth would warrant replacement for restoring function, aesthetics, and a patient's self-esteem. However, in the presence of disease or conditions affecting the tooth, the decision to preserve or extract would depend on factors such as severity of disease, response to treatment, and patient's compliance. In terms of prognosis of the tooth, the location and number of missing teeth and the type of prostheses required will influence the complexity of the case. As an example, replacing a single missing tooth in the posterior region is less demanding compared to replacing a missing tooth in the anterior region, because the aesthetics of the final outcome is less critical in the posterior region. Generally, the diameter of implants ranges from 3 to 5 millimeters, and the length of implants ranges from 6 to 17 millimeters. An implant must be entirely covered by adequate bone, about 1.5 to 2 millimeters, for functional and aesthetic purposes. Therefore, for an implant to be placed, there must be adequate bone width and bone height. The space envelope required will depend on the diameter and length of implant to be placed. This space requirement must be considered at both the intercrown to interroot level. Lack of bone availability will make the treatment more complex, expensive, and demanding for the patient, as additional procedures such as soft and hard tissue grafting will be required. Depending on the location of the missing tooth, the implant placement site may be in close proximity to vital structures, such as a nerve or blood vessels. Encroaching on these structures may result in perioperative and postoperative complications, such as bleeding and paresthesia. In the posterior maxilla following tooth loss, the maxillary sinuses may be pneumatized, and if bone height is not sufficient for a short implant, sinus lift procedures have to be considered. Infringement of the nasopalatine vessels during implant placement to replace the centrals may result in bleeding intraoperatively. However, this is not life-threatening and can be controlled. In fact, the canal space can be grafted to facilitate ideal implant placement. In the mandible, one of the structures to consider is the inferior alveolar nerve. It is a mandibular branch of the fifth cranial nerve and enters the medial part of the ramus into the lingula. It traverses downwards and then runs obliquely within the body of the mandible. The nerve usually divides into the mental and incisive branch at the premolar region. The mental nerve emerges from the mental canal. Precautionary measures must be taken during placement of implants in the premolar and molar region to prevent any encroachment into the mental nerve and the inferior alveolar canal that may result in neurological damage and sensory disturbances to the area that they supply, which includes the lower teeth, lower lip, and chin. The lingual nerve is too part of the mandibular branch of the fifth cranial nerve and located lingual to the third molar. It may be injured during lingual flap elevation. Submental and sublingual arteries are major nutrient vessels to the submental area and floor of the mouth. These arteries may travel closely to the lingual plate. Fenestration of the lingual plate during implant placement in the mandible may result in artery damage. If undetected and not controlled, this may result in hemorrhage that causes swelling at the floor of the mouth. The swelling will then press the tongue upward and backwards, resulting in airway blockage, and the patient may go into respiratory distress. Implant support in bone significantly differs from tooth support in bone, in that they lack the periodontal ligament that act as shock absorbers. Forces transmitted via the tooth is absorbed and dampened by the PDL before being transmitted to the bone. For implant forces, they are transmitted directly to the implants and the bone. For a natural tooth, excessive forces result in mobility of the tooth, and when the force is removed, the tooth goes back into its normal range of physiologic movement. However, the implant reacts by resorption of the bone and mechanical failures such as fracture of the implant components, the restoration, or the implant itself. The bite force exerted during parafunction is greater than normal. Although these conditions are not contraindicated for implant placement, they make treatment planning more critical for the selection of implants, design of the occlusion, prosthesis material, and finally maintenance. Parafunctional habits include bruxing, clenching, and tongue thrusting, and some signs to look out for in patients include wear of the teeth, fracture restorations, muscle tenderness, and noises made during sleep. Most times, the treatment of these patients may require a multidisciplinary approach. When planning a case, another important consideration is the restorative space. For the retention and resistance of the final implant prostheses, adequate occlusogingival space is required. Space consideration must take into consideration the height of the transmucosal components and the thickness of the final prostheses required for its strength. The space required from the implant platform to the opposing tooth would be about 7 mm. This takes into account the biologic width, implant abutment height, and crown thickness. The space requirement for screw-retained versus cement-retained prostheses are the following. Minimum vertical height from the opposing tooth is 7 mm for abutment and cemented crown, and otherwise 5.5 mm for screw retained. Margins should be kept accessible and ideally supragingival using customized abutments to prevent problems to the peri-implant soft tissues caused by remnant cement. It is important to build implant skills gradually and select cases that matches one's degree of clinical proficiency. Useful tools have been developed to help clinicians identify the overall risk of implant treatment. The SAC, Simple, Advanced and Complex Classification, was developed in 2006 to aid diagnosis and treatment planning for implant cases. The recently updated Aesthetic Risk Assessment, included as a clinical modifier in the SAC, considers some key clinical factors that may compromise an implant treatment. Based on this set of checklists, a patient requiring an implant can be categorized into low, medium, or high level of risk. These factors include medical status, smoking habit, gingival display at full smile, width of edentulous span, shape of tooth crowns, restorative status of neighboring teeth, gingival phenotype, infection at the implant site, soft tissue anatomy, bone level at adjacent teeth, facial bone wall phenotype, bone anatomy of alveolar crest, and patient's expectation. Some of these factors will be discussed in the upcoming slides illustrated using clinical photos. Let us look at gingival display as one of the factors that may compromise an implant treatment. A beautiful smile is considered as one of the treatment goals of dental implant. Gingival display is considered as a risk factor as demanding surgical and restorative skills are required to achieve healthy and well-contoured mucogingival tissues. In an average smile line, 75 to 100% of the maxillary incisors and interproximal tissues are exposed. The placement of implants in this patient is less than ideal. It was mentioned earlier that a minimum bony envelope surrounding a dental implant is 1.5 mm. Taking this into consideration, the inter-implant distance must be 3 mm. Failure of this has resulted in the loss of bony peak between the implants. The unsupported loss of interdental papilla in this case has been overcome using prosthodontic camouflage of creating a long contact point between 1-1 and 2-1. Considering that the patient has a low smile line, the final aesthetic outcome is acceptable and the patient is satisfied. Next, we will look at the shape of tooth as one of the aesthetic risk factors. Triangular teeth are often associated with gingival architecture of highly scalloped and thin biotype. This usually is an aesthetic challenge, whereas square teeth are most often associated with thick gingival biotype, and it's easier to maintain the interproximal papilla with square teeth. Tissue biotype can be divided into thick and thin types. Asians generally have thin biotypes and Caucasians have thick biotypes. Problems with thin biotypes include recession, metals shining through the prosthesis, and generally poor aesthetics. This is a case of a patient with triangular-shaped teeth and highly scalloped gingiva. According to Choquet et al. In 2001, black triangles will be expected when the incisor-cervical distance between the proximal contact to the bone crest is greater than 5 mm. In this case, a small black triangle can be seen following implant crown placement. In most cases, the complete closure of the black triangle would require restoration of the adjacent tooth. Now, we will go through the final example of an aesthetic risk factor, the width of the edentulous span. Implants in the extended ridge pose an aesthetic challenge as most of the time there is lack of both hard and soft tissue and will require grafting. Loss of multiple teeth also results in loss of bony bone peaks. It is surgically demanding to achieve an ideal mucogingival architecture, as it is impossible to create the interdental papillae due to the lack of support following loss of the interdental bone peaks. Proper implant placement is highly important, and any efforts aimed at preserving the bone must be employed. Guidelines for implant placement of adjacent implants and soft tissue development have been proposed to optimize aesthetic results. The rule of 3x3x3 PIE is a mnemonic based on biologically and prosthetically driven implant placement, which was introduced by Priest in 2007. The 4 interdependent principles of the rule are as follows. Platforms of the implant should be located 3 mm apical to the zenith of the predetermined facial gingival margins of the planned restorations. The centers of the implants should be placed at a distance of at least 3 mm palatal to the anticipated facial margins. An inter-implant spacing of 3 mm is required between adjacent implant platforms. And finally, the implants should emerge through the palatal incisal edge of the ensuing crown positions. This patient had lost her anterior bridge following an accident during an anesthetic intubation procedure, resulting in severe bone deficiency in the areas of teeth 1-2 to 2-3. The photograph depicts the anterior ridge following hard tissue grafting to increase the bone width for placement of regular size implants. The grafting and implant placement were carried out in 2 separate procedures. 3 implants were placed to replace 5 missing teeth, taking into consideration the space requirements as per the PIE concept, as well as the bone availability following grafting procedure. With proper planning, it was possible to provide the patient with the final processes of porcelain fused to metal screw-retained bridge that fulfills both aesthetics and retrievability. This is the list of references for your further reading. Do comment and share your thoughts with us.